Hello everyone, welcome back to the Tokyo Living Podcast, Injury Edition. Today we're going to be discussing headaches. Now, headaches is generally not something that we would consider or classify as an injury, and it's probably a lot of people that don't recognise the contribution of the musculoskeletal system in different headache types. So we're going to be discussing today the different headache types and the degree to which physical interventions such as manual therapy and exercise can be effective in the management of headaches. Now, I think this is a relevant topic as some of the other things that we talk about, things that people might not experience. Hopefully most of us don't go through an ACL reconstruction. A lot of people won't experience tendinopathy, but I think most people will experience a headache of some degree of frequency or intensity at some stage in their life. And there's probably many of you that do have frequent headaches. And so I think it is relevant to a lot of people. Now, as I said before, we do have different types of headaches. Now, this is maybe something that intuitively not a lot of people think about. We might think about different areas of the head where we might have headaches or different intensities, but might not think of them as having different causes or being a different sort of clinical entity. Now, whilst we do have distinct headache types with quite specific diagnostic criteria, it's thought that up to 50% of headaches are not pure strains of headache, that they're actually a combination of different types of headache. We have what we call primary headache and secondary headache. So a primary headache is basically a headache that originates in the head. So it's related to the neurological and hormonal activity that's actually occurring in the brain. Whereas a secondary headache is referred from some other source. The most relevant secondary headache that we're going to be talking about today is a cervicogenic headache. So a headache that is primarily influenced by the neck. So the main headache forms that we're going to be talking about today are, like I said, cervicogenic headache, tension headache, and migraines. However, there are quite a number of other headaches that one might experience. We have cluster headaches, which is a less common form of headache, and this is something that's generally felt around the area of the eye. It's quite intense, but it's quite a small sort of area of pain that one would experience. These are often associated with reaction to different smells and different pollens, and it's thought to be related to the release of histamine. These can often come on for minutes at a time, and so in relatively short duration, but one can experience multiple episodes of these short duration cluster headaches for weeks and up to months. Similarly, we can have sinus headaches. So sinus headache is generally bilateral, so on both sides, whereas a cluster headache is more unilateral. And a sinus headache, as you would expect, is sort of located closer to the eye sockets and is usually associated with other symptoms of sinusitis, so congestion and symptoms like that. We can have exertion headache. This is again a relatively rare form of headache, but it is actually something that I've experienced myself. So it's something that will come on with exertion, activity, exercise. In my case, it came on when I was performing a heavy leg press. I believe it was probably 15, 16 years ago. I had an acute onset of a headache. And then I experienced that headache. It was a very low level headache at rest, but it would spike to a relatively strong intensity with activity. And so this is what people experience, that it stays at a low level, but when they exercise to a certain intensity, or it can even come on with sexual intercourse, they start to get this headache come on a lot stronger. Luckily for me, I did respond to pharmacological management for this exercise or exertion headache, and there are different medications that you can use for this headache, and it's a little bit of trial and error involved. We also have alcohol-induced headache. Now, if you're experiencing one of these, this podcast is about helping people, and you might not get you might not get as much sympathy if that's the case. But I mean, all jokes aside, if this is something that you experience on any degree of frequency, then it's obviously something that you need to look at from a lifestyle management perspective, and might even require onward referral. But that's perhaps something for another episode. We can also have medication-induced headache, and this is an interesting one where it gets into a little bit of a vicious cycle where we use medication for whatever form of headache we have, whether it is a tension headache or a sarcogenic headache, or indeed a migraine. And then if the headache frequency starts to increase, we increase the frequency with which we use that medication, and that in turn can actually induce further headache. So it's thought that if we use medication for headache more than half the days of a month, so more than 14 or 15 days of a month, then this can actually then become the primary driver of the headache. So if this sounds like something that you're dealing with, if you use headache medication quite frequently, and you do find that you are getting more frequent headaches as a result of it, and if you're using medication more than half the days of the month, then it's probably worth discussing this with your doctor, and if possible, trying to look at other alternative treatments and looking towards weaning off that medication. We can also have hypnic headaches, again a fairly rare form of headache that generally affects people in the latter half of their life, generally from about 50 years onwards, but this sort of headache only appears at night. We can also have headaches that are related to more sinister pathologies. So we always want to rule out red flags. Headaches can be the result of a tumour, that can be a result of an aneurysm. I know when I had my exertional headache, I was sent for investigations for cerebral hemorrhage, because that is a differential diagnosis for an exertional headache. So if you have had a headache that has come on acutely after a bout of activity, it is important to get imaging to rule out any sinister pathology. And that sort of goes for everything that we deal with in musculoskeletal medicine, but it's probably even more prudent with in the case of a headache. So before we go on to discuss the three types of headaches that we're going to spend a little bit more time on, I want to talk about a little bit of anatomy related to the head. And as always, I'm probably going to do a terrible job of simplifying this, but a key element of our anatomy related to headaches is what we call the trigeminal cervical nucleus. Now, this is an area of the brainstem, so it's the lower part of the brainstem that comes down to the approximately C3 level of the spine. So I think most people understand that we have different vertebrae in our spine, and the top three vertebrae of the neck, we have this part of the brainstem, and it's basically a hub of neural activity where we have inputs from the trigeminal nerve, which is the largest branch or the largest of our cranial nerves originating in the brain. And this sends a lot of sensory information from all over the head, the face, the jaw, the eyes, and it comes down, and as it enters the trigeminal cervical nucleus, we also have sensory input from the top few levels of our neck. So from the cranium down to C3, we have information coming from joints, from muscles around the neck, and it all converges in this hub of neural activity. So when we have increased sensitivity in those nerves, so that might be local increased sensitivity from the brain, or it might be local increased sensitivity from structures in the neck, it all converges in this hub and can lead to the production of pain and the other symptoms that are associated with the headaches. And so we can have what we generally term as a bottom-up or a top-down initiation of a headache. So a top-down would be something like a migraine or a tension-type headache where it's actually originating in the brain, it's coming down, and because of that, the trigeminal cervical nucleus is becoming sensitized, and we can get secondary neck pain associated with that. Or a top-up onset of headache would be where we have some tension in the neck, we might have some restricted range of motion, maybe even some inflammation, some increased tension in the muscles around the neck. That increases the sensitivity in those local nerve fibers that then go into the trigeminal cervical nucleus and then cause the headache through the connection with the trigeminal nerve. So we know that around 18% of all headaches are cervicogenic headaches, or primary cervicogenic headaches, where the main cause of the headache is coming from the neck. Around 70% of all headaches are associated with neck pain. So in some cases, we have the neck actually causing the headache. In others, the neck pain is more thought to be a result of the headache. And so in the cases where it's a primary neck issue, then obviously treating the neck should result in a positive outcome in reducing one's headache pain. If the primary source of the headache is originating in the brain and the neck pain is secondary to the headache, then addressing the neck pain or addressing neck dysfunction is not necessarily going to impact the head in the same way. However, there's an Australian physiotherapist who's a specialist in headaches, Dean Watson, looks at it a little bit differently in terms of instead of isolating the headaches to specific forms and focusing only on neck treatment for cervicogenic headaches. He thinks of it more as a headache coming on when you have sufficient sensitivity in the trigeminal cervical nucleus. So you might have inputs from the neck that are coming in from, I guess if you're looking at the trigeminal cervical nucleus being the spine, you know, the neck inputs are coming in from the side, and then the head inputs are coming in from the top. And it's almost like if you think about having a glass of water, you have inputs, you have a certain amount of water coming from the brain, a certain amount coming from the neck, and once the water overflows through that glass, then you start to experience pain. So you might have, you know, a certain amount of neck tension or stress that's there the whole time, but then you have your head-driven symptoms that cause that trigeminal cervical nucleus to overflow and have the symptoms of a head. So when we look at these specific headache types and the diagnostic criteria for each, with migraine, it's usually something that comes on relatively early on in one's life. So the average onset, age of onset for a migraine is 18. And unfortunately, once someone experiences migraines, they usually experiencing them for the entirety of their life. It affects females more than males at a ratio of about 1.7 to 1. It's probably 50% unilateral, so half of migraines will occur only on one side of the head and will usually cause pain and other symptoms not only in the head but all through the face as well. They're often associated with other symptoms, and the main symptoms are nausea and sensitivity to light and sound. So we call these photophobia and phonophobia. They usually have a throbbing quality, and for most people, these headaches are brought on by specific triggers, but the trigger can be very different for each individual person. So it might be changes in hormones, it might be changes in stress, it might be certain physical activity that brings it on, it might be certain smells, certain foods. I mean, foods is a big one, and most people will have their foods that they've experienced as a trigger for their migraines, and most people have sort of learned to avoid those foods over time. And also medications. So people will have a reaction to certain medications that bring on their migraine. In terms of the cause of the migraine, again, we talked about migraine being one of the primary forms of headache. So it's associated with changes in the neural activity of the trigeminal nerve, and often associated with changes in hormone and different chemicals in the body. So especially serotonin is one specific chemical that's been shown to be upregulated in migraine sufferers. And then people generally experience these symptoms in stages. So the first stage is what we call prodrome, where people have almost at the onset of a migraine, they know that migraine is coming. They start to feel some of those pre-symptoms. That then develops into what we call aura, where we start to have some of that phonophobia, photophobia, the nausea. That then develops into the third stage, which is where we have the actual pain associated with the headache. And then after that, we have what we call postdrome, where people feel that they're just not right, the element of fatigue, and just that inability to function normally. We can also further divide migraines into episodic and chronic migraines. This is sort of based on the International Headache Society. An episodic migraine is 5 or less migraines per month, whereas a chronic migraine is 15 or more headaches, but 8 of those being migraines. So someone who suffers chronic migraines might not be suffering a migraine every time they have a headache, but the majority, more than half of their headaches that they suffer, will be migraines. Then we go into tension type headaches, and tension type headaches are also primary headache type, so they're originating in the brain, and they're thought to have perhaps a similar sort of mechanism of onset where you have a hormonal and a neurological upregulation of the trigeminal nerve, and that leads to pain. Now, these generally aren't associated with nausea. You don't get the aura that you have with migraines, but occasionally photophobia and phonophobia may be associated with a tension headache. The area of the headache is generally bilateral, so people will experience this on both sides, and it's more sort of in around the temple area, and it has more of a pulsating quality rather than a throbbing quality, and tends to be not as severe as a migraine in terms of the intensity of the pain that one would experience. These headaches might last from several minutes up to an entire day. They also tend to be more common in females and tend to be more common in younger people, generally sort of 20 to 40. Stress tends to be a large driver of these headaches. So when someone is under psychological stress, both from an acute perspective, so if someone is having a stressful time, they're more likely to experience the onset of a headache at that time, but also chronic stress. So someone that has high levels of ongoing stress in their lives are more likely to develop tension type headaches. And also other detrimental elements of lifestyle, poor sleep, smoking, excessive alcohol use. All these things are thought to contribute to the onset of a tension headache. And then we have our cervicogenic headache. So this is a secondary type of headache that is driven primarily by issues in the neck. Now, this actually tends to be more common in males. The average age of onset of a cervicogenic headache is a little bit older, so around 33. These are generally unilateral, so most of the time when someone's experiencing a cervicogenic headache, it will be just on one side of their head, and it tends to be more towards the back. So we have it almost sort of around the top of the neck on one side, up into the skull, and it may sort of come around into that temple area. It will often be aggravated by certain neck positions, so people might find that if they're using a computer and their head is in that sort of forward jutted position, that might be putting stress on that part of the neck and therefore contributing to the headache. And also positions where we're in a degree of rotation, where one side of the neck is a little bit more compressed than the other, may also lead to an aggravation in the headache. Because these type of headaches are originating in the neck, as a physiotherapist, obviously when we have someone presenting with a headache, we want to assess the neck. Now, we do know that even in migraine and tension type headaches, there will be some decrease in neck range of motion. The decrease in neck range of motion with a cervicogenic headache is likely to be greater. However, range of motion alone isn't sufficient for diagnosis of a cervicogenic headache. However, if we use a cluster of tests where we combine range of motion with control of the head and neck area, we look at the coordination and the endurance of the muscles, and palpation, so we're pushing on those areas in the upper part of the neck, and a lot of the times we can reproduce the headache. So when we push on one side compared to the other, I mean this area of the neck is quite sensitive, and if we push hard enough, even on an asymptomatic neck, we can often reproduce some pain in the head, but generally it will be much stronger on the side where someone has their headache. Now, when we talk about treatment for headaches, there are certain parts of the treatment that are relevant for all types of headaches. I discussed earlier, medication management. So there may be the need to discuss someone's medication with them and their doctor, and if they are on headache medication that is starting to build and actually become a primary cause of the headache, then that needs to be addressed. Stress management, so if headaches are triggered by stress, then we need to look at strategies of managing stress, and that might involve consultation with a mental health practitioner as well. Identification of triggers. If we're talking about migraines, then someone needs to be aware of their triggers and try to control them. Obviously, if their triggers are dietary, then they need to learn to avoid the foods that trigger their headaches. If it's other triggers that they're aware of, then just trying to adjust their lifestyle where possible. However, there are differing opinions on this, and this sort of goes back to, in a way, the concept of load. And again, if you haven't listened or watched the episode that we did on load, this sort of underpins how we manage every condition that we manage in a physiotherapy environment. But there is the argument that we almost need to develop tolerance to these triggers, like we would develop tolerance to a physical load, allowing our muscles and tendons and bones to become stronger and more tolerant to the loads that we put them under. There is the argument that the same thing should be done for triggers. So one might have their headache or even their migraine spike with a certain amount of a certain food. And so if we know that amount, we can just gradually build up our tolerance by eating slightly less than that amount, and then slightly start to edge towards an amount of that food that might trigger it. But as we're doing that, we're hopefully lifting the ceiling on the amount of that food that we can consume before our headache is triggered. And we can apply that sort of trigger tolerance to whatever the trigger is that we're experiencing. With a tension type headache, same thing. If we notice different triggers, if it's something other than stress, then we can, in some ways avoid it initially, but then look at a strategy for trying to increase our tolerance. General exercise is recommended for most types of headaches. Now, if someone is experiencing a headache at that actual time, it may be difficult to exercise. It might be that the exercise itself causes an increase in their headache. But where possible, during the time in between bouts of headache, trying to increase the amount of exercise along with other elements of a healthy lifestyle is likely to decrease the frequency and hopefully also the intensity of headaches that one might experience. When it comes to cervicogenic headache, some of the specific management strategies, sleep. Now, sleep we obviously need to address with the other types as well. So getting a good night's sleep will help decrease the likelihood of a tension type headache or a migraine occurring. But with cervicogenic headache, we're probably looking not only the quality and quantity of sleep, but also the position. So we know that some neck issues are aggravated by a sleeping position, and so we may have to adjust the position that we're sleeping in, and also maybe the number of pillows. So we're in either as neutral a neck position as possible, or if we know that certain positions, let's say if a side bending of the head towards one side starts to reproduce the headache, then maybe using enough pillows so that we're slightly tilted away from that side to decrease that compression occurring. Manual therapy and exercise, I guess, is what most people think of when they think of physiotherapy, and obviously those are two of our key tools that we use. And manual therapy has actually been shown to be effective not only for cervicogenic headaches, but for other headache types. And I think this goes back to that concept, that Dean Watson concept that I talked about before, that even though something might be a primary migraine headache, it might be tipped over the edge by sensitivity of the neck. And so by doing some manual therapy and some exercise around the neck, we can decrease the sensitivity of the neck-related structures, and that can decrease the overall sensitivity of the trigeminal cervical nucleus and therefore decrease the pain. With a cervicogenic headache, however, any sort of exercise or manual therapy intervention that decreases whatever it is in the neck that's causing the problem, if it's a lack of range of motion, if it's excessive muscle tension or tone, then that is likely to improve the headache. Now, with manual therapy, we've talked and written about manual therapy in the past, and for some manual therapy techniques, it's thought that they're relatively non-specific, and it doesn't really matter what you're doing or where you're doing it. It's the interaction with the patient or the client that's actually driving the changes and the benefits that are occurring as a result of that manual therapy. With the cervical spine, and I talked about this in the neck episode, again, I'm keep pointing over here. I'm hoping that the links I'm putting to previous episodes are appearing here if you're watching on YouTube. If you're watching on Instagram or somewhere else, then I'm just pointing in the air and it means nothing. We talked about the upper cervical spine being a little bit more sensitive to manual therapy interventions. I think because when you look at the joints up in the area, they're very small, they're very finite. I think we can actually have a more specific impact on that area of the body compared to other areas of the body. And through personal experience, now that we can make specific changes to one's range of motion with manual therapy techniques, and that usually results in a decrease in their headaches. And we know from research that manual therapy in the upper cervical spine can lead to not only temporary changes in headache frequency and intensity, but also ongoing long-term changes. So this is one area where I am quite confident that manual therapy is a really valuable part of exercise intervention. Sorry, a physiotherapy intervention. Exercise, we talked about general exercise being important, but specific exercise for the neck is important as well. We can use exercise to try and decrease local sensitivity, but if we have control and coordination issues in the neck that are driving the problem, then we can use specific exercise to address those coordination issues, and by doing so, hopefully decrease the stress on the neck. And then, anything else that might be impacting the neck. We talked about it in our neck episode, how when we have someone who's experiencing neck pain, we want to assess different systems in the body. We want to assess the jaw, we want to assess the eyes and the oculomotor and vestibular system. We want to see someone's balance, because all of these can be influencing someone's neck pain. So if other systems of the body aren't coping with load, then the neck can often be that area that tries to take up that extra stress and becomes hypertonic and painful as a result. So if someone does have a headache that we believe is primarily cervicogenic, then we need to unpack that and perform an entire cervical spine assessment. So I hope that has been of interest for some people. If you are a headache sufferer, particularly if you have got headache associated with neck pain, or even if you are a migraine sufferer and haven't tried physiotherapy or other physical therapies in the past to try and manage your headache, then it might be worth a go. If it is primarily a migraine or a tension type, then we may not be able to make any change, but in our experience, there's a good chance that we can at least decrease the frequency and the intensity of those headaches. And definitely if you've got a headache that is related to neck pain and it matches what we described as the typical symptoms of a cervicogenic headache, then it's definitely worth looking into some more physical management for the problem. And obviously, physiotherapy doesn't generally have the risks associated with pharmacological use, particularly long-term pharmacological use. So, as always, thank you again for watching, and if you have topics that you would like us to speak on, please let us know. Otherwise, we'll look forward to seeing you on the next episode. Thanks for watching. Thanks for listening.